Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting and we're coming to you from Meanjin, the land on which this podcast is being recorded.
Hello, I'm Maggie Robin, Community GP, Rural GP Obstetrician at Beaudesert Hospital and Coordinator of Mater's GP Shared Care Education Program.
In this episode, we're talking about hypertension in pregnancy with Dr. Vishwas Raghunath, nephrologist and obstetric physician.
Vish works at Ipswich and Mater hospitals, managing complex medical conditions in high-risk pregnancies and also at the Westmoreton Kidney Health Service.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Hi Vish, welcome to sMater.
Hi, thank you so much for having me here.
Now, hypertension is the most common medical problem encountered in pregnancy. In Australia, 30,000 women each year will develop high blood pressure in pregnancy, and for a third of those, it leads to preeclampsia. So it becomes a health concern for life for these women, doesn't it?
Yeah, absolutely. It's one of those interesting relationships where we certainly believe that pregnancy is a bit like a stress test here, where it identifies some women who are at higher sort of cardiovascular risk and then allows them to manifest preeclampsia, which then translates to a higher future risk as well. And what's important there is that the understanding of this future risk has become more apparent just in the last few years, whereas historically we used to believe that we could often cure preeclampsia just by birthing baby. Whereas now we know that that's not entirely true in terms of better guidelines that are being available to follow up these women as well.
The SOMANTS hypertension in pregnancy guideline has recently been updated and approved by the NHMRC. What has changed and what's new in the guidelines?
What's new in this guideline is the fact that we've gotten a bit better information about how to screen for women for preeclampsia. How do we have strategies? There's some more clarity around prevention strategies for preeclampsia. The management of hypertension in itself hasn't changed too much, but there's some clarity around what targets we need to meet. And then subsequently, once these women have delivered, we have a bit more information on what to do after birth, and just making sure that they're linked in for annual health checkups and thereafter. So to make sure that the future health is well preserved.
So when we see someone in general practice who perhaps is preconception and planning a pregnancy, and perhaps they have some risk factors in their history, we know obviously to take their blood pressure and pay attention to that, but what other things should we be asking about, testing and looking for to prevent preeclampsia?
Oh, that's a great question. I think one of the important things is that most of these women will be in the community in primary care. So having primary care working well with the hospital-based services to try and identify these women at risk is quite crucial. A set of risk factors the standard high-risk factors would be certain pre-existing conditions that we often look for. Particularly the big-ticket items would be pre-existing hypertension, pre-existing diabetes, either type 1 or type 2, underlying autoimmune conditions such as systemic lupus erythematosus or rheumatoid arthritis or nephrotic syndrome for that matter, and also a previous history of preeclampsia. So if this woman has had preeclampsia in the previous pregnancy, there's a good chance that she will get this in the subsequent pregnancy. Now, these are probably most of the main risk factors, but you've got a few smaller ones such as advanced maternal age, BMI, IVF pregnancies as well. So there are quite a few things that we can go through which the guideline highlights as well. And often recognizing these conditions is a pathway to working towards reducing their risk as well. So you could, if you have a few risk factors that you do identify, you can select these women out and then talk to them about individualized screening to further delineate their risk, and then some prevention strategies. Particularly most important will be the use of aspirin and calcium early in the pregnancy. We suggest with the new guidelines that we use 150 milligrams of aspirin every day, preferably at night, to improve compliance, right from about 12 to 16 weeks, definitely under 16 weeks, and through the remainder of the pregnancy till about 34 to 36 weeks. And that goes a long way in reducing the risk of preeclampsia, particularly under 34 weeks, but also later preeclampsia as well. Alongside the use of calcium, for example, in women who have low-ish calcium diets would be quite useful as well in reducing the risk of preeclampsia. And we normally recommend 1 or 2 tablets of calcium in this regard based on their dietary intake.
What about non-pharmacological treatments?
Now, traditionally, we've known that things like exercise are really good for us. But here we have a good body of evidence which has been endorsed in this guideline to show that some good exercise for about 2.5 to 5 hours a week goes a long way in reducing the risk of preeclampsia. Now, this could be aerobic exercise or even some mild resistance training works really well in this regard. So I think that is the most important sort of non-pharmacological measure. And there are a few other things like changes in diet and lifestyle, which would be quite important as well.
Vish, what are the type of hypertensive disorders that develop during pregnancy and which one's the most serious?
This is really important because you've got a wide variety of hypertensive disorders in pregnancy now. As you might know, historically this used to be termed as pregnancy-induced hypertension, which we understand now is a bit of a misnomer. Now, you could have pre-existing hypertension that women bring along to the pregnancy journey, but if you look at new onset hypertension in pregnancy, particularly after the second half, after 20 weeks in the pregnancy, you're looking at a couple of groups. So you've got gestational hypertension, which tends to be the more commoner variant. And then you've got preeclampsia, which is a marker of gestational hypertension, plus some evidence of either maternal or fetal dysfunction. And you've also got other smaller kinds of hypertension, for example, white coat hypertension. There is some relevance in pregnancy. Mast hypertension, which is a different kind of hypertension where you've got normal blood pressure in the clinic scenario, but you've actually got high blood pressure at home. For some of these, you actually need an ambulatory blood pressure monitor to make a diagnosis.
What is it about preeclampsia that sets it apart from gestational hypertension or chronic hypertension? What suddenly tips someone over from that into preeclampsia?
It's a great question. I think the lines are sometimes a bit fairly blurred. The hallmark of preeclampsia would be so gestational hypertension is purely the development of hypertension where you have a blood pressure of over 140 or 90 millimeters of mercury. The development of preeclampsia requires some marker of maternal organ dysfunction. Now, this could either be traditionally what we'd recognize for proteinuria as a marker, which is not necessary for diagnosis anymore. It can be there, but it's not necessary for diagnosis anymore. Acute kidney injury, for example, a serum creatinine that's a bit more elevated than usual. Now, typically in pregnancy, a creatinine of more than 90 micromoles per liter is considered abnormal, whereas outside of the pregnancy, this would very much fall in the normal range. So that's something that we have to be attuned for. Liver dysfunction in the form of transaminitis, neurological events such as seizures or intractable headaches and hyperreflexia, pulmonary edema or periorbital edema. Some of these are manifestations as well. And importantly, from 2014, or rather the 2018 definition, when they brought in fetal dysfunction as well, so placental dysfunction in the form of fetal growth restriction. And that's an important definition as well. So these are some of the things that will probably indicate that preeclampsia has developed.
Okay, so someone who has high blood pressure and fetal growth restriction, that would qualify as preeclampsia.
Yes, yeah, based on the current guidelines. So if you're able to demonstrate fetal growth restriction in the absence of other common conditions such as infections or other purely maternal etiologies, then that would amount towards a definition, yeah.
You mentioned edema, and pregnant women often report edema. It seems really common to get swollen feet, swollen hands. It's not necessarily a diagnostic criterion for preeclampsia though, is it?
No, that's a very good question. Peripheral edema, like you highlighted, is quite common in pregnancy. Particularly what the guideline has spoken about is pulmonary edema. So if you have a new onset pulmonary edema, which often manifests with either orthopnea or PND, would be something to consider. Also, when you develop facial or periorbital edema, that would be something to raise a red flag as well. But yes, you're quite right in the sense that the peripheral edema is quite common.
Looking at the management of a chronic or gestational hypertension, what antihypertensives are best for women in pregnancy?
Currently, SOMANS recommends a few medications that are quite safe. There's good, robust data for their safety in pregnancy as well. Traditionally, the first-line medications would often be labetalol, which is a beta blocker, methyl-dopa, a centrally acting agent, and nifedipine, which is a calcium channel blocker. Now, these three have a good safety data, not just in the management of chronic hypertension in pregnancy, but also new onset hypertension as well. They're short-acting medications, which means that they're administered a few times a day, which is something that the women need counseling about, as opposed to outside of pregnancy, where you can get away with once daily medications. And we can always consider the use of additional agents such as prazosin or hydralazine to be used as second line as well.
Any contraindications for those medications, methyl-dopa, labetalol, nifedipine?
Beta blockers, as we know, we have to ask about a history of asthma, so they might have some increased bronchoconstriction as a consequence of that, so we'd like to avoid that. Methyl-dopa is generally avoided in someone who's got a history of recent clinical depression, because it can worsen mood swings as well, and that's another variable we don't want to deal with. Nifedipine, to highlight that it might cause some headaches in some of these women, and you can have some reflex tachycardia occasionally. But again, these are some things, if you counsel women the right way, you can pick a first-line agent which works really well. And often we find that we might, as time goes on, need combinations of medications, so we just talk them through that journey as well.
What about those who are on ACE inhibitors for hypertension before their pregnancy? Should they be transferred onto something different for pregnancy?
One of the important things is, I think historically we used to always say that we have to stop ACE inhibitors prior to even starting their pregnancy planning. Now, this is okay if you've got someone with well-controlled hypertension, or let's say if they're on an ACE inhibitor for proteinuria with kidney disease. And if it's stable, that's fine. But you have a cohort of women who either have uncontrolled hypertension or have significant proteinuria, where stopping this quite early, and bearing in mind that it can take a while for someone to get pregnant as well, might risk further increase in proteinuria, which can have consequences as well. So the current teachings or the current guidelines recommend continuing an ACE inhibitor or an ARB, angiotensin receptor blocker, till you confirm a pregnancy, at which point it's safe to stop these medications. Now, I must stress that under no circumstances should we continue using these medications once the pregnancy has been confirmed, particularly in the second and third trimester. They're definitely contraindicated then.
What are the challenges with aspirin and dosage, and what should GPs know to tell their patients?
Aspirin, as I mentioned earlier, should be commenced in anyone who's been identified as having a high risk of preeclampsia, and we generally recommend starting that before 16 weeks. 150 milligrams is the recommended dose, so it's still classified as low-dose aspirin, but it's a bit tricky in Australia because we don't have 150 milligram tablets. What we often recommend is using the 300 milligram soluble tablets, break it in half, but importantly discarding the other half because they do not stay well. Using aspirin at night is best recommendation purely because it improves compliance. Now, we have shown studies, particularly out of Australia as well, where compliance has been shown to be linked in with the size effect of aspirin as well. So, and that's why it's really important to use aspirin at night. And if you start using aspirin at that point in time and continue through till about 34 to 36 weeks, you get the best result for aspirin. There are a small proportion of women, however, who might have acute gastritis as a consequence of aspirin, and that you may have to vary recommendations. And also, as we're increasingly seeing women who have recently had bariatric surgery, but for the most part, using aspirin is beneficial.
You mentioned calcium earlier, but you said if dietary intake is adequate, potentially not needed. Is that right?
There is, yes. So in summary, yes, but it's important to clarify their dietary intake. Now, the new guideline also provides a link to a calcium scoring system in the diet, and that gives us a better idea. It's often hard to quantify how much calcium a woman takes, but using a multivitamin or a single dose of calcium on top of their diet isn't unreasonable on a practical basis to make sure that you're getting that added layer of protection as well.
We've talked a bit about women who have pre-existing hypertension and women with risk factors. What about someone who perhaps has no past history of hypertension and they're pregnant and we discover that their blood pressure is high? What should be our approach in general practice to that?
I think the big number to consider is 140 over 90 millimeters of mercury. Now, if their blood pressure is just at or above that range, I would definitely recommend getting a baseline set of additional information. So we, of course, when we check the blood pressure in the office setting for the first time, we repeat it as we normally do. Once that has been confirmed, I would definitely recommend doing some baseline blood tests to look at a full blood count, a Chem20 panel to look at serum creatinine and liver function tests as well, and a urine for a protein creatinine ratio. Now, this would give us that information to see if they meet criteria for preeclampsia. Now, if they don't meet criteria for preeclampsia, and then they would be classified as gestational hypertension, and they're clinically well. Of course, the other clinical features of preeclampsia we have to be mindful of as well, such as no evidence of brisk reflexes or clonus, no headaches, no right upper quadrant pain, and those sorts of things. We could commence them in any of those first-line agents, such as labetalol or methyl-dopa, and close monitoring would be crucial. So a lot of these women, as I've said before, the lines between progressing from gestational hypertension to preeclampsia are quite blurred. So we would recommend frequent monitoring of these women, so at least on a weekly basis, and refer them on to a hospital-based system. Because once these women have developed new onset hypertension, we have to try and do as much as we can to gather more information on risk. So in general, we would recommend transferring their care from community-based care to a hospital-based care so they can get additional maternal and fetal surveillance.
Is there a particular blood pressure cutoff where we should be not waiting and not repeating measurements, but just sending someone straight to hospital?
Absolutely. So severe hypertension would amount to a blood pressure of over 160 over 110 millimeters of mercury. And regardless of whether they have symptoms or not, if this is a confirmed true blood pressure reading, they need to be coming to hospital straight away, either to the emergency department of your local hospital or the pregnancy assessment center here at Mater Hospital.
What about due date? Do these women that we're talking about, do they need to deliver earlier?
Look, that's an interesting question. So the timing of delivery is always a difficult question in some women with any hypertensive disorders of pregnancy. Now, if you've got someone with gestational hypertension who's got well-controlled blood pressure on a single agent, there's no reason that you'd have to bring this forward, any delivery forward. We can watch the woman through, but the important thing is close surveillance. If someone develops preeclampsia, in my practice, it's unusual that they get too many more weeks out of that particular pregnancy. And often, particularly if they have an increasing requirement for additional antihypertensive agents or some changes in baby's growth, then often those would be the triggers for planning for early delivery. Now, the recommendations, particularly through the new guidelines as well, would suggest that at between 36 to 37, nearly 36 to 38 weeks is probably going to be ideal, unless you're faced with a situation where you've got rising high blood pressure.
The Maternal Fetal Medicine Pregnancy Research Centre at the University of Melbourne found that in Australia, preeclampsia is the indication for 20% of labour inductions and 15% of caesarean sections. It also accounts for 5 to 10% of preterm deliveries.
Are there times when preeclampsia or the other hypertensive disorders of pregnancy become so severe that there's indication for urgent preterm delivery?
Yeah, unfortunately, particularly working at the Mater, when we tend to see a lot of quite unwell women as well, is that when you have preeclampsia with a particularly severe phenotype, and this would be someone who has escalating need for antihypertensive medications, so there are a number of medications, they're having symptoms on and off, and they're having changes in their biochemistry and pathology that you can monitor, or worsening fetal indices in the form of growth restriction or abnormal findings on Dopplers as well. These would be women where we'd start planning for delivery early. Now, it's always a tightrope walk, purely because of the fact that you want to make sure that both mum and bub are healthy. The delivery planning between 36 and 38 weeks becomes very individualized in this setting. But yes, early delivery planning for the safety of both mum and bub will be considered in them.
And what about earlier gestations than 36 weeks? Are there any interventions that can help improve the outcome for baby if they need to be born even more preterm?
Prior to 36 weeks, again, it's a difficult situation, but often if it looks like the chances of baby being born are better than baby being in mum, and mum is demonstrating worsening signs and symptoms of preeclampsia, then delivery planning would be quite imminent. Now, the mode of delivery is something that can be also very individualized. Now, it's not automatically required that someone needs to have an emergency cesarean section. A lot of these women can be induced and have vaginal births as well, but it is an issue of timing. So if timing is critical, then we're probably looking at trying to decide the appropriate mode of delivery.
So moving to the postnatal period, mothers left hospital and back to care with their GP. What advice do you have for GPs and keeping an eye on these women?
Yeah, no, that's an excellent question. Within the first few weeks of delivery, we still have to monitor mothers very closely. So it's quite likely that any local hospital, whether it's sMater or any other maternity hospital, will be following up these women within the first couple of weeks. Now, once their blood pressure, if they've got a blood pressure management plan and they're still on antihypertensive medications, we often adopt a shared care model with GPs to continue their management of blood pressure thereafter as well. They need to be seen at about 6 to 8 weeks after birth, and that's important. And the newer guidelines are also recommending a review at about 3 to 6 months after birth as well. And that's important because we don't want to lose this window of opportunity. And that's something that's quite crucial in a woman's journey through pregnancy, particularly dealing with these sort of effects of the stress test that the pregnancy is. That shows that most women who have any hypertensive disorder in pregnancy tend to have a higher blood pressure than age-matched cohorts in the first year postpartum. So following them up at the 6-week mark, maybe 3 to 6 months, depending on what's possible, and then thereafter having an annual health check is very crucial. Annual health check would comprise an overall assessment of their cardiovascular health and blood pressure checks and weight gain as well.
When we're treating hypertension postpartum, if they're still needing medication, do we change the agent?
There are a few more medications that are available in our arsenal to manage blood pressure after delivery as well. Now, what we tend to find is, particularly as I've highlighted before with methyl-dopa, for example, there's a higher risk of mood disturbances, and in the immediate postnatal period, that could be troublesome as well. We often tend to use ACE inhibitors like enalapril or captopril. They are quite safe in the immediate postpartum period. They have been used to be safe in breastfeeding as well. The other benefit of using these groups of medications, they can be twice daily medication instead of 3 times a day medication, and compliance certainly improves with that, particularly when they've got a newborn at home.
Vish, are there particular biomarkers in early pregnancy that GPs should think about testing for when we're looking for preeclampsia risk?
And it's one of my favorite things about preeclampsia is biomarkers as well, because there's so much promise. Now, the research is delivering, but it's still underway. Now, what everyone may have heard of is this thing called the SFLT-PLGF ratio. It's often, or in other states, it's called the PERT test, the preeclampsia risk test. Now, SFLT is the soluble FMS-like tyrosine kinase molecule, and PLGF, of course, is placental growth factor. And all this ratio highlights is the imbalance between sort of pro-angiogenic and anti-angiogenic factors within a woman with preeclampsia. The guideline through SOMANS has highlighted the fact that if you have a situation where the clinical context is a bit unclear, you're not quite sure if this woman has preeclampsia, but you'd like to know, then doing this particular test, now bearing in mind that access to this test is very limited as well, largely to bigger centers. But if you can get a ratio, and the number that you may have read in the papers is again under 38, and that's quite reassuring, mainly for its negative predictive value. So having a ratio of less than 38 would rule out preeclampsia. Now, if you think about the importance of that, particularly in Australia, would be a lot of women in regional centers. That allows us that little bit of time to work them up and then facilitate transfer to larger centers, as opposed to having to do it in a fairly rushed way, which might have some unknown consequences as well. So it's an important area of research. There's a lot of work happening within Australia as well. It's not quite become a purely diagnostic marker yet. The committee acknowledges that there's a fair bit of research going on, and certainly the future will be promising in this space, because you will have the presence of some more guidance around how to use this better outside of the current use.
Vish, it sounds like there's lots of work being done in this area at the moment. What do you see as the future in treating hypertension in pregnancy?
The future is bright. The future is promising. There's a lot of work happening in Australia, and it's so great to be part of the obstetric medicine group in Australia, because I think we're amongst the world leaders in this space, where the kind of research that's happening here with international collaborators is quite excellent. There's a lot of work happening in preventative strategies, as can be seen through the SOMAN's guideline as well. There are quite a few promising groups of medicines that are being trialed to see if they have a good benefit as either an adjunct to aspirin to prevent preeclampsia. So that's an interesting space to watch out. We're getting better at personalizing treatment, and I think that's important. So the future certainly will move towards a personalized approach where we want to fine-tune treatment strategies, not only looking at how they respond with the blood pressure point of view, but can we use any other investigative markers? Now, there's some studies that have looked at using echocardiography as a way to guide treatment management as well in these women, and that certainly has been used in some centers, but we're just waiting for more data to make that a bit more applicable generally. The postpartum space is something that I'm quite passionate about. It's extremely important. And as I've said before, it's a unique window of opportunity that only a woman gets to try and identify their cardiovascular health. And whatever intervention you do in the first few years after a diagnosis of any hypertensive disease in pregnancy has lasting benefits for more than 10, 20, 30 years into the future. Unfortunately, preeclampsia is associated with a 2 to 4 times higher risk of heart failure, stroke, death, and chronic kidney disease. So making a difference where you can look at adjusting their cardiovascular risk is quite crucial. And there's definitely something happening in the area as well that we would work towards improving their healthcare.
Sounds very promising. Vish, thank you so much for joining us today.
Thank you very much for having me. It's been great.
Before you go, though, we have a little surprise. It's a segment we like to call the checkup. So we have 5 quick questions from Maggie, and they're just finding out a little bit about you as a medical professional and as a person as well. You ready to go?
Yep, sure. Let's give it a go.
Vish, when you were a little boy, what did you want to be when you grew up?
An astronaut. Yes, didn't work out quite that way, but I still love astronomy, so I love stargazing.
Describe your handwriting.
My handwriting? Well, I'd like to think it's quite legible. I quite enjoy writing, and I think that's one of the... I'm very much a paper and pen kind of a person, so I still make notes.
What do you like to do to unwind?
I love listening to music, going for hikes. They're some of the things that I love to do with the kids and the family. It's great. I mean, we're lucky to live in a place that has access to walking tracks and hiking tracks. That's brilliant.
What's the best outfit that you have ever worn to a costume party?
Elvis Presley, actually.
Oh.
And I won the Best Dressed award, which is interesting, given that I have 2 left feet and I just can't dance. So
But you looked the part.
well. I looked the part.
Yeah. You had a medical student with you right now. What single piece of advice would you like to impart to them about their future?
I think just drawing on my own personal experience, being open to opportunity is something that I always encourage. I tell all my juniors that my own journey towards obstetric medicine and nephrology has been not quite, it's not that I wanted to be an obstetric physician when I first started off. I became a nephrologist, and I sort of stumbled into obstetric medicine when I worked with someone who was quite passionate with it, and I just found that it clicked. And I think just being open to that, just the fact that sometimes opportunities come laterally, and if you're able to seize them, I think you'll be happier.
It's been great having you here today, Vish. Thanks for joining us on sMater.
Thank you so much for your time. It's been great fun.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.